Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Education Program Manager. It's my pleasure to serve as host of the CGNE Seminar Series, along with amazing assistance from Jenny Rank, CGNE Education Program Specialist. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Bridging Aging in Critical Care and Rural Health, Findings from a Mixed Methods Needs Assessment, will be presented by Dr. Anna Krupp, Assistant Professor at the University of Iowa College of Nursing, in collaboration with Dr. Leah Buck, Director, and other friends at the Somé Center for Gerontological Excellence. Before the presentation begins, we do have some announcements and disclosures to make. Penn State Ross and Carol Neese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Participants with a valid RN license that attend the entire activity and complete the post-event evaluation within 1 week can earn 1 contact hour. Partial contact hours are not awarded. Certificates will be emailed to RN participants meeting all requirements within 1 month following the seminar. As a reminder, the seminar is being recorded. If people don't have an opportunity to watch it live, we do post all of the recordings up on YouTube. So if you've missed something throughout this academic year and you'd like to go back or rewatch something, please know that those are available to you. If you have any questions or comments for our speaker today, you can enter them into the chat feature, or you can use the raise hand feature and Jenny will unmute you so you can speak aloud. The post-event evaluation link will pop up in your browser when the webinar concludes. It will also be emailed to participants within 24 hours. We do require this for RNs seeking contact hours, but we really would love for all participants to complete the evaluation to assist with our data collection. If you have any questions or concerns, you're always welcome to reach out to us at cgne@psu.edu. And now it's my pleasure to welcome Samia Al-Dahami, a CGNE affiliate graduate student in her second year of her PhD program. In addition to her studies, Samia has become interested in the Age-Friendly University initiative here at Penn State, and she has recently joined our task force. So we look forward to her contributions towards this initiative. Thanks also for being here today, Samia, and introducing our speaker.
Thank you, Jenny. Good afternoon, everyone. It's my pleasure to introduce our speaker today. Anna Krupp is an assistant professor at the University of Iowa College of Nursing. Her program of research advances clinical decision-making and care delivery in critical care environments. She integrates clinical informatics and implementation science to improve ICU outcomes with a focus on mobility intervention, clinical decision support, and innovative use of electronic health records in research. She leads and collaborates on federally funded projects supported by AHRQ, NIH, and ARBAH, and her contributions have shaped national guidelines for ICU care. With more than 14 years of experience as an ICU nurse and clinical nurse specialist, Dr. Krupp brings a deep practice-informed perspective to her scholarship. Please join me in welcoming Dr. Anna Krupp. We will look forward to your insights today. Dr. Krupp, the floor is yours.
Good afternoon. Thank you so much for the invite to present some of my work here today. As mentioned, I'm planning to describe bridging aging in critical care and rural health, and we'll end with finding from a mixed method needs assessment. So over 5 million adults are admitted to an ICU annually in the US each year. And approximately 50% of those ICU admissions include older adults. And so critical illness really is a key aging issue as older adults have higher ICU mortality and risk of developing complications after ICU admission. Yet ICU admission enables survivorship of otherwise life-threatening acute illnesses. And so really thinking about how we optimize recovery from critical illness requires attention not only to survival, but also long-term outcomes that enable patients to thrive. So today I plan to present on how variation in ICU outcomes that I witnessed in my clinical practice really motivated my program of research in understanding implementation strategies to increase adoption of evidence-based guidelines. I'll plan to talk about key evidence-based guideline recommendations in the ICU and also care for older adults in intensive care unit settings, and describe research examining implementation strategies to support uptake in clinical practice. And then I'm going to end with describing how this work has informed a needs assessment that we're currently conducting to think about how we can better inform future quality improvement and research efforts more broadly to enhance care in ICUs across varied contexts. So critical care is widely considered as the care provided in specially equipped and staffed geographic areas in a hospital, namely ICUs. However, critical illness follows a continuum, which starts before hospital admission and continues well beyond ICU discharge. And gaps at any point in that care influence patient outcomes, from delay in recognition that a patient requires ICU care, gaps in care provided in the ICU, and even breakdown in communication about post-ICU care. So while this is sort of visualized as a continuum, patient care is often fragmented. One challenge is that a majority of clinicians who provide ICU care, the nurses, physicians, therapists, tend to work in ICUs, but don't follow patient care before and after ICU admission. And so this persistent challenge has really motivated my program of research. While my current work focuses in the ICU setting, I'm really motivated to help the critical care continuum be more visible to ICU clinicians and patients, and thinking about how we improve long-term patient outcomes. So one specific challenge in critical care continuum is the high incidence of post-intensive care syndrome, or PICS. So this is sort of the lens that we're going to use today in thinking about my program of research and really thinking about how we can reduce the incidence of PICS because it's a quite frequent complication of ICU care. So as advances in healthcare and technology have increased survivorship of patients in the ICU, a growing body of research shows that long-term outcomes for many patients who survive an ICU admission do not return to their pre-admission abilities. It's estimated that about 50 to 80% of adults experience at least one or more post-intensive care syndrome impairments that might persist for months to years after their hospital discharge. So post-intensive care syndrome, or PICS, is an umbrella term. It includes impairments in mental health, cognitive impairments, physical impairments. This impacts patients' finances and their broader family impact. So really thinking about the persistent impact of an ICU hospitalization. And this is particularly important for older adults. We know that over 1 million older adults survive an ICU admission, but they're at heightened risk for developing PICS because of unique factors and considerations. We know that conditions such as functional and cognitive decline are potentially vulnerable because of pre-existing frailty, disability, multimorbidity, and/or cognitive impairment. So compared with patients of younger age, older adults are at increased risk for developing post-intensive care syndrome. And this is particularly important because in studies of health outcome prioritization, older adults rank maintaining functional independence, which can be impaired by PICS, as one of their most important health priorities over survival, really necessitating the consideration of long-term functional recovery, both during and after ICU care. So I'm just going to take a minute to zoom in on one component of PICS, which is functional impairment, and thinking about older adults and their pre-admission functional status is really important in understanding their potential recovery after critical illness. Chronological age does not tell the whole story. Really, the pre-existing characteristics, such as functional status, are really important. So following a cohort of patients aged 70 years or older, those who experienced a hospitalization and had baseline mild or severe functional impairment in those blue and yellow bars had both a 2 or 3 times greater likelihood of early mortality in the year following ICU discharge and more functional impairments compared with patients that had minimal disability prior to ICU admission. So one might wonder, is it ICU admission or just hospitalization in general that puts patients at risk for functional decline? And there have been comparison studies looking at patients who are admitted to an ICU versus those who were admitted to a hospitalization. And really, we find that post-ICU disability is greater than post-hospital disability. So it's really important to know about a person's hospitalization, including if they were admitted to an ICU or not, as an important part of care transitions because it has subsequent impact on patients' recovery after their ICU stay. And so really understanding components of their hospitalization are important in the recovery trajectory. One last piece about functional recovery, as specific to older adults, is that there are predictors of functional recovery. So looking at potential predictors, those that are associated with lower functional recovery in older adults include hearing impairment and vision impairment. And factors that improve functional recovery include increased BMI and higher rates of functional self-efficacy at baseline. And importantly, these represent modifiable factors when we think about how we might maintain or improve functional recovery for older adults. So we've talked about post-intensive care syndrome, factors specific to older adults within functional decline. I want to zoom out again and think more broadly about post-intensive care syndrome and potentially modifiable and modifiable factors. So I want to transition to talking about a clinical practice guideline that's been a key part of my program of research that really targets potentially modifiable and modifiable factors associated with post-intensive care syndrome. These are specifically mechanical ventilation, ICU length of stay, sedation use, delirium, and immobility. So the first clinical practice guideline I'm going to talk about is known as the ABCDEF bundle. This is a bundle of clinical interventions that are delivered by the ICU team while a patient is in the intensive care unit. And so this multi-component bundle is part of a clinical practice guideline from the Society of Critical Care Medicine. And really the overarching goal is to maximize wakefulness and encourage cognitive and physical activity. And this really is multi-component interprofessional approach. I'll take a minute to talk about each of the bundle elements. I mentioned it's interprofessional, but you'll see really nursing has a thread through each of the A through F components. So A describes assessing and managing pain. B is specific to patients who require mechanical ventilation, and this describes both awakening and breathing trials, so assuring that patients are awake and interactive while their breathing trial is occurring. C describes choice of pain and sedation medications, so managing patient symptoms while using the lowest dose of medication required to do that, and also including non-pharmacologic strategies. D describes delirium assessment and management, and many of the management strategies include non-pharmacologic interventions. E is early mobility and exercise, encouraging patients to engage in mobility as soon as they're physiologically stable, ideally within the first 24 to 48 hours of ICU admission. And then F describes family engagement. So these guideline recommendations apply to every ICU patient every day, regardless of mechanical ventilation status, diagnosis, or age. A patient simply receives the bundle element for which he or she is eligible. And so ways that these clinical practice guidelines have been woven into practice can start with hospital policies that describe these evidence-based practices. Institutions might also have order sets and then documentation and electronic health records so that clinicians can document these interventions and assessments occurring at routine intervals. So on that note, much of my research has focused on how we adopt these evidence-based guidelines into routine care. There has been a lot of work done on this front, including a nationwide quality improvement collaborative aiming to accelerate bundle adoption into routine care. This included 68 ICUs and over 15,000 critically ill adults. Units received training and quality improvement initiatives and education around the bundle. And then at the site level, they track processes and clinical outcomes while doing their quality improvement work. Across the collaborative, implementation of the ABCDEF bundle was associated with shorter ICU and hospital length of stay and lower mortality. This slide also shows that there is a dose-response relationship. So patients who received more letters of the bundle had better outcomes. So we can see that if patients received at least about 50% of the bundle elements or greater, their outcomes were improved. So the whole bundle is best, but more is better than nothing. The study also looked at adoption, and the slide or the figure on the left shows that at the beginning of the collaborative, before the intervention, baseline adoption of the complete ABCDEF bundle was low, around 3 to 4%. And after a 22-month collaborative, we did see an increase in adoption, but you can see it got to about 12%. So while that was, a several-fold increase, broadly, it's still pretty low full adoption. And so then next steps in the research are to ask, why is there continual low adoption? One way to better understand this is to look at the individual bundle elements. So the slide on the right shows among the individual bundle elements what was pre and post collaborative performance. And you can see, for example, that the letter A, or assessing and treating pain, is quite high, which we would expect. That's sort of a common practice. Where other elements, such as early mobility, the letter E, were quite low at pre-collaborative and really had sort of a modest increase. So I think this helps speak about the complexity of certain bundle elements and the benefit of partnering with clinical partners such as DNP projects, thinking about local adoption as a potential idea to think about what's so specific to your unit in increasing adoption of these multi-component bundles. Another question to ask in trying to understand this barrier between what we know, the bundle, and sort of why there's still low adoption is to look at the barriers. And so there's been several articles published on barriers to adopting the ABCDEF bundle, and they found over 100 barriers. And so in efforts to further distill the barriers, group concept mapping grouped barriers to implementing the bundle into core categories. Categories include feedback in that light orange category, processes and procedures in green, for example, and then personnel and equipment in brown. So again, trying to distill hundreds of barriers into 5 or 6 main categories. And then also working with end users to say, to successfully deliver the bundle, what should be in place to help you deliver the bundle better? So this is helping to understand some potential barriers that might be interventions for future studies. So before I talk about the study that's currently underway, I want to provide just a brief one-slide overview of implementation science to help orient the research lens with which we're approaching the study on the ABCDEF bundle. So implementation science focuses on methods to promote the uptick of research findings into routine practice. And the first question we want to know is, what is the thing that you're trying to promote adoption of? And so in our case, the thing is the ABCDEF bundle. This is the innovation that improves public health. If we were doing efficacy and effective research, we would ask, does the ABCDEF bundle work? Do we see improved patient outcomes? And I've already shown that. So then from an implementation research question, we ask, how do we best help clinicians deliver the ABCDEF bundle? So this question helps us think about strategies and interventions on a unit or system level to help clinicians in delivering evidence-based practices. And one common approach that we use is designing and testing implementation strategies. So implementation strategies are the actions that we take to help others do the thing, such as the ABCDEF bundle. An important information and understanding implementation strategies are what are those barriers. So in the previous slide, I said there's lots of barriers. We use that to help focus our implementation strategies. So to help sort of make this make sense, I want to then share about the current trial that I am working on as part of a large multi-site team. So Best ICU describes a multi-site pragmatic trial being led by Michelle Ballas from the University of Nebraska Medical Center and Ed Vasilevskis from the University of Wisconsin. Across 3 health systems, we are trialing on an ICU level what are effective implementation strategies for increasing adoption of the ABCDEF bundle. So what strategies might help clinicians deliver more of the bundle, more days to patients? This is an ICU level intervention, so it's 12 ICUs across 3 health systems, and we're targeting around 8,000 patients on mechanical ventilation. So I mentioned that we're testing implementation strategies. We're testing 2 of them. So ICUs might be randomized to either this strategy or the next one. So first strategy is real-time audit and feedback. Again, feedback was a common barrier where clinicians just didn't know their current performance around delivering the ABCDEF bundle. So this is a dedicated video screen in the ICU that summarizes existing electronic health record documentation to show completion status of each bundle element. So you can see by a red, yellow, green, the completion status of each bundle element. Again, visible to all clinicians and patients in the ICU. The second implementation strategy is a nurse facilitator. So this is a specially trained nurse who helps the ICU team implementing the ABCDEF bundle. This nurse works 8 hours a day, Monday through Friday, without a patient assignment. We believe this is one of the first studies to test adding an additional nurse in the ICU as it relates to implementing evidence-based practice. And this strategy really builds from the barriers around workload. As you can imagine, mobilizing patients in the ICU takes hands and workload. And so the idea is, does adding more nurses help support the team in delivering the bundle more effectively? So the facilitator works within a couple different domains as a facilitator, a coordinator. They also provide some real-time performance monitoring and feedback to clinicians and provide coaching and championing. So some of the ways that I've seen this being implemented in 2 of the ICUs where I'm at that have been randomized as intervention is a lot around mobility. Nurses are spending a lot of time helping patients mobilize more frequently and at higher levels because they have the time. They're also providing education to patients and families around ICU care and why they're focused on the ABCDEF bundle. And then also, I had another example of a nurse facilitator who put together a nice kit of sleep hygiene tools. She could see that in Central Supply, you could order face masks and earplugs, but she recognized that that wasn't being done. So she brought that information to the unit. So again, a lot of really, I think, innovative strategies at the unit level to identify unique barriers. So this study is currently underway through September of 2026. Our primary outcome is bundle performance. So do more patients get more of the bundle elements? And then we're also looking at duration of mechanical ventilation as our primary clinical outcome. And then lots of secondary outcomes. All of this is being collected through existing electronic health record data. Really not taking any additional work from ICU clinicians. We're using existing documentation, but a lot of work behind the scenes really harmonizing this data across the 3 sites. So before I move on from the ABCDEF bundle, I just wanted to pause and highlight how I really do think that many of the ICU nursing interventions from the bundle align with the 4Ms framework, and would love to discuss potential opportunities for further alignment and thinking how we might better align age-friendly interventions in the ICU. But several of the bundle components do seem to fit or partially fit the 4Ms framework. So I'm going to transition to a second evidence-based practice guideline, again, really focused on post-intensive care syndrome and some of the potentially non-modifiable factors that are important for older adults related to frailty, disability, cognitive impairment. And this recognizes that hot off the presses guideline, this was just published by the Society of Critical Care Medicine just within the last month, really focusing on caring for older adults in the ICU. Recognizing unique factors and considerations relevant to their care, and a real need for evidence-based recommendations to guide critical care clinicians, given a limited geriatrician workforce. And so this guideline has 2 conditional recommendations and 3 no recommendation statements. It's going to really briefly talk about the 2 recommendations. The first recommendation really tries to answer the question, should older adults receive a geriatrics consultation or geriatrics model of care upon ICU admission? And it was a conditional recommendation with low certainty to suggest a geriatric model of care for older adults admitted to an ICU. This recommendation was generated from 2 RCTs and a pilot trial examining models of care or consultation during an ICU stay. And pooled effects found that really a lot of uncertainty around the outcomes of interest, such as mortality, incidence of delirium, and discharge to a location other than home. So one of my favorite things about reading clinical guidelines is trying to understand what their future research priorities are. And so I've included them here as well. We're thinking about investigating age-friendly models of care, implementation, and fidelity in ICUs, along with other care models. And I think it also recognizes that while it may be difficult to implement due to resources, what are other models we might want to consider given limited resources? The second question focused on should older adults admitted to the ICU receive antipsychotics for prevention of delirium. And this conditional recommendation with very low certainty was suggesting not using antipsychotic medications for prevention of delirium. The evidence supporting this recommendation included 3 randomized control trials, and the challenge was that they were unable to draw population-specific conclusions, given those previous trials enrolled patients that were primarily in their 50s to early 60s, and one study even excluded adults over 65. So because antipsychotics are high-risk medications for older adults, really thinking about potential adverse events, that the guideline really wanted to think about not wanting to cause potential harm during or after critical illness. And then research priorities really in focusing on enrolling older adults with critical illness, and also really understanding the fidelity of non-pharmacologic bundles. So lots of opportunity as well to think about these 2 questions in future research priorities. So I want to wrap up my talk by focusing on the needs assessment. So I've described unique challenges that older adults admitted to the ICU experience, evidence-based guidelines for reducing post-intensive care syndrome or PICS. But much of my research has been in urban academic health centers. However, we know the rural population is aging and growing. I see this in my own family. I grew up on a small farm, and I have aging parents who are aging in place in rural Wisconsin. And so really this has motivated interest around thinking about where else ICU care is delivered and how we can help support care across the continuum. So there's been some research recently looking at how ICU care characteristics differ across rural and urban settings. In a study of Medicare beneficiaries receiving ICU care between about 2010 and 2019, it shows that care in rural hospitals is increasing. About 12% of ICU admissions happen in rural ICUs. And importantly, over time, patients are getting more complex. They have similar levels of organ dysfunction as patients admitted to ICUs in urban settings. And we know that rural hospitals are threatened by unique workforce shortages and financial strain. So, really trying to think about how we can optimize care across settings is an important question. Another way to think about ICU characteristics relates to specific diagnoses. We know that regionalization is common in certain populations, but little is known about patients with sepsis, which is a common diagnosis on why older adults are admitted to ICUs. And so Nick Moore led a study looking at rural sepsis patients and finding that patients who initially sought care in rural areas have higher transfer rates. And those patients that transfer have higher mortality and length of stay compared to non-transferred patients. So this growing literature base really motivated our research locally to really understand at a state level or how is ICU care provided and the types of patients receiving ICU level care. So I'm really grateful for funding from the Some Center for Gerontologic Excellence here at the University of Iowa, supporting a collaboratory we call Optimal Aging in Iowa across the critical care continuum. This work is being done in connection with Heather Dunn, who is an acute care gero nurse practitioner. Jacinda Bunch is a researcher interested in for that early warning systems and also does a lot of work in simulation. Nick Moore is an epidemiologist at the College of Medicine who's done work around sepsis across the region. And then Jim Blum is a partner in health systems research. So really excited to form this robust team and helping answer questions around the characteristics of older adults requiring ICU level care across Iowa, and also understanding characteristics of Iowa hospitals delivering ICU level care. So across the state of Iowa, there are 28 rural referral or urban hospitals and 3 rural hospitals. And ICU care is also delivered in critical access hospitals across the state. We've identified 14. The previous research I mentioned looking at ICU level care did not include critical access hospitals, but we felt it was important to include in our exploration because they do frequently care for ICU level care. So we first wanted to better describe ICU use across Iowa hospitals. We used a limited data set from the Iowa Hospital Association between 2016 and 2023, and just wanted to describe characteristics of older adults who received ICU level billing, and also looked where they received care. Was it in urban settings, rural, or critical access? And so I just want to point to a couple of findings that we saw looking at the average age of patients receiving ICU level care as older in critical access hospitals with a median age of 80. We see that patients come from a variety of sources, but importantly, the rural referral or urban, about 20% of their patients were transferred from another hospital. So I think it really speaks to that fact of older adults potentially leaving their community to receive ICU level care. Major diagnostic categories were sort of consistent across, their cardiovascular, respiratory, or infectious reason across the 3 sites. And then finally, recognizing that about 20% of patients required some sort of skilled nursing or rehab after their ICU discharge. Our future work is looking to better describe of those patients who transferred, if there's any patterns around their disease categories or discharge disposition to better describe patient needs of ICU care across the state. But this is sort of our first descriptive work from this data set. Secondly, an effort to understand ICU needs across Iowa hospitals, we're conducting a phone survey of ICU nurse managers across the state. We are asking a short, 10 or 12 structured questionnaire looking at the types of ICU services available without transfer, the composition of the ICU team, topics of quality improvement that are important to their ICU or hospital, continuing education opportunities. And then we end the call with an open-ended question that says, knowing that everyone has nursing staffing challenges, what is the most common unmet need you encounter when caring for older adults in your ICU? So we're really trying to think about, from their perspective, what's an unmet need that we might not have asked about in our phone survey. So going into this work, I knew that nurse managers are busy and difficult to contact, but it's taken us more calls than I thought to connect with nurse managers. So I'm only about a quarter of the way through the phone survey at this point. However, when we do connect with nurse managers, really getting some valuable information about their current opportunities and challenges locally. And one of the themes that we're finding so far is low opportunities for continuing education for nurses once they complete their ICU orientation. So this work is ongoing. I plan to wrap up this summer. So I wanted to close just thinking about future work and how this needs assessment, and my prior work in implementing evidence-based care is helping me think about future steps and potential future collaborations. In our needs assessment, identifying that education is a primary need right now, thinking about, are there opportunities to develop a learning collaborative across the ICUs in the state to promote networking and advance evidence-based care? I'm curious as well to think about how a nurse facilitator type strategy might help support that learning collaborative and really sort of build that networking across the state potentially. In addition, I'm also interested in thinking about how we might develop and test implementation strategies across hospital types that may have lower frequency of some more complex conditions, but still really need the ability to provide evidence-based care across hospital types, and also support care transitions for those who receive ICU level care, but then thinking about coming back to the community and potentially that increased risk for post-intensive care syndrome, really supporting that recovery beyond the ICU. So at this point, I just wanted to say thank you for the opportunity to present some of my work today. I'd love to talk more if anyone's interested in the types of questions or topics I've brought up. My email is here if you'd like to reach out for a potential collaboration, or I'd love to talk now a little bit more. So thanks for your time today.
Oh, thank you so much for this amazing presentation. It's been a while since I've been in acute care and worked in the ICU, so it was wonderful to learn about all the things that are going on and the great background you provided in terms of PICS and the ABCDEF bundle, and not only, the barriers, that you also identified through the exploration, as well as what you're doing with your current work. So thank you so much for sharing all of this. I know that we've got a few comments in the chat that came in while you were speaking. Early on in your presentation, Sarah Songer says, or is it the post-ICU decline due to the usual complexity of meds, care, and follow-up at discharge to someone with a mental decline? Any comments or thoughts about that?
I really appreciate that comment, and I think it speaks to the complexity that absolutely the opportunities for post-ICU care, I think, are really vast. There are some pockets where institutions have specific post-ICU follow-up clinics that look at some of these exact things. Like, are there medications that were started in the ICU that should have been discontinued that haven't been? Really thinking about are patients able to connect with the therapy and services they might need to facilitate recovery? It's a field that's growing, but we recognize that there are lots of factors that support that recovery afterwards as well.
Yeah, thank you for those comments. Sarah also questions, she said, do you have any data on the use of non-ICU settings? I know your focus was ICUs, and you talked about the three different types of, clinical settings you were really evaluating. But, in your literature review or your knowledge of other studies, Did you come across any information about non-ICU settings?
So, part of my research interest is specifically in the E letter of the bundle or early mobility. And what we do
Mhm.
know is that there have been studies that have shown that, ICU initiatives have increased mobility in the ICU. But if there are not those programs to sustain mobility after their ICU discharge, we see mobility drop. So I think it does really speak to, thinking about that whole picture, not considering just their ICU, but how if we start some of these interventions in the ICU, how they then can continue in the post-acute phase as well to promote some of the work that we're starting. That's sort of my thought specific to early mobility. Um, but I know that I think it's consistent as well in thinking about, risk for delirium and not getting a lot of sleep in the ICU and how we can help as soon as possible provide sleep-wake cycles and then continue that throughout their hospital stay. I think
Yeah.
opportunities to break some of those silos are really future opportunities I'm interested in thinking about.
Yeah, it's so many opportunities, it feels like. And so I'm really thankful that you're doing this very important work. And there's many comments about what a wonderful presentation this was. Um, Even specifically, your slides were very well designed, easy to read and understand. Thank you for doing that. Lots of thank yous for sharing this research that you are conducting right now. Um, so Donna's asking, for your assessment of a nurse to help with mobility, speaking of mobility, are you involving a health economist to cost it out?
So this is the things that I learned as part of a large team and sort of in retrospect, wish it would have been the fourth aim of the grant, but just didn't have the money. The facilitator is an expensive intervention. There's currently an RO1 underway with the cost effectiveness of it. So we'll have that after the trial. However, in thinking about the learning health system and how we might sustain this intervention, what we're trying to do is help the health systems who are interested in this intervention look at some of their own data. So, are there some other metrics that might sort of lead to costs that might be meaningful for them in thinking about this investment? So, for example, one of the metrics that's important to some of the directors I talk with is length of stay, and so they're sort of tracking their length of stay prior to the intervention and then after the nurse facilitator to see if there's movement around length of stay. I would
Yeah,
like to think
that's
so.
wonderful.
Yeah.
And I appreciate Donna asking that question because I think, when you're advocating to a health system for, programmatic change, including something like the nurse facilitator, which, as you said, is a unique role, someone that doesn't take a patient assignment, but yet is really focused on the bundle and all the implementation strategies that are recommended, all the care planning and things like that, really coaching staff and monitoring um, performance and things like that. That's going to cost something, right? So if you
Absolutely.
can show the benefit of that in some way, maybe there would be more interest in that kind of thing. Jenny,
Yeah.
it looks like we have someone that's unmuted
We
or joined
actually,
us.
Donna has her hand raised. So
Okay.
I'm gonna, Donna, if you want to add anything on to that comment or question that you had.
Yeah, thanks, Anna. It's an excellent presentation. I can tell you're doing work that's gonna like be helpful immediately. So that's so great. I was just thinking that you can probably easily find this online, but we did a cost analysis of our delirium work. And I think you could still describe, it sounds like you already have an RO1 for cost effectiveness, but I think even with this study, you could work with a health economist and even do it yourself and just describe some of the cost of that person. And then also look at some of your cost avoidance, right?
Yes.
So,
Great point.
but looking at their time, if there's even if you're still in the midst of it, do a mini time analysis because a lot of cost is really time. And that would
Those
really set you up for your next study. It's great work.
Yeah,
Great
those
work.
are Great points, because qualitatively, we know that the units love the facilitator, the physical therapist, the respiratory therapist, really the entire ICU team is like, how do we keep this? Another component that we're measuring that I didn't include today is also burnout, to see if this impacts nurse burnout. Because at least what I hear from nurses is they'll work in the facilitator role for 2 days, and then they'll do their regular clinical duties for 1 to 2 days a week, and that balance is sort of fulfilling to them.
A similar question in the chat, Khaled is asking, um, is it common to have one nurse without an assignment implementing EBDP? And do you have any data that support this approach? And you may have mentioned it and maybe we missed it, but do you have any specific data at this point relative to that approach?
I think the role is a great question. Primarily, I would see this as the role of the clinical nurse specialist or clinical nurse leader, which is a role I did clinically for over a decade, and I loved it. However, the clinical nurse specialist role usually has multiple initiatives, and usually isn't able to be at the bedside 8 hours a day, 5 days a week. So, because this role is protected, they don't get pulled into staffing, but they also don't get pulled into meetings. So they really are sort of at the unit level, and focused on the bundle. We've had a lot of interesting conversations though around, like, if this was sustained, how do we sort of support their role? And if it were to creep because it needed to, or if, they did get additional assignments added, for example, like, oh, now you're also doing, CLABSI prevention, sort of all these other hospital initiatives. I'm trying to sort of balance that.
Yeah, it's hard to balance.
Yeah, yeah.
Jenny, is Ahmed ready to share? Okay. So we have a graduate student joining us, Ahmed.
Ahmed, you can go ahead and unmute and ask your question. No.
Yeah. Ahmed, are you able to unmute? Okay. Well, while he's working on that, Solomon, another one of our graduate PhD students, again says, great presentation. I'm interested in how the family piece of the bundle to help facilitate mobility and recovery, how that unfolds.
You're asking a question that a PhD student that I'm working with is also very interested in. So how can we
Cool.
sort of use complementary elements of the bundle to have some synergy? More of the work I see in this area is happening in the pediatric intensive care unit, and family members being involved in mobility. I don't see as much right now around the role of family members engaging adults in the ICU in mobility activities beyond sort of providing positive reinforcement and goal setting. But I think a really great opportunity potentially. Also recognizing that they'll have more familiarity with the patient's pre ICU abilities and sort of what their baseline functional ability was, and then thinking about how that can help support them as well in the care transition to be involved in the ICU stay.
Yeah, and I like the way that you had one slide related to your interest in discussing and exploring further how this aligns with the 4Ms framework. And what caught my eye was the what matters and family engagement. I was curious about what matters also can relate to the patient themselves, of course, and what their goals and priorities for care and their life are, which can help, hopefully drive the whole care planning process. Do you have thoughts about how the 4Ms framework can, relate to more of this work?
I mean, I think when I started to sort of see the overlap, I was really excited and thinking
Yeah.
about how we might be able to build from existing work. So if we're already, working on doing the bundle more effectively, are there ways we might want to tailor it to ensure that care for older adults fits within there? Beyond sort of overlaying the bundle, I was curious to hear others' perspective on that.
Yeah, so if people have comments or things that they'd like to share related to that, please feel free to either raise your hand and we'll unmute you, or you can add it to the chat. Dr. Diane Barish does have a question for you in the chat. It says, to what extent might care coordination or transitional care help with continuity and/or sustainability of interventions after someone is discharged from the ICU to another unit or back home or perhaps to skilled, rehab services?
Yeah. Um, I have a lot of ideas around that, but one of the first thing
Mhm.
that comes to my mind is sort of this invisibility that, ICU clinicians really don't know what happens post ICU care, and really understanding that, their interventions and helping a patient get out of bed more often and more frequently helped support that patient to go home rather than potentially requiring, inpatient rehab after their ICU stay. So I think making that more visible is really important. And then also sort of bringing the unique nuances of, what ICU care meant as part of a patient's transition in care, that they're at higher risk for potentially post ICU complications. Um, at least at work locally, I see care transitions not necessarily happening beyond the unit level. So at the ICU care transition manager will hand off to the floor. So I don't maybe see the continuity that might be really interesting to support.
Yeah, and as a former director of nursing in a subacute setting and skilled nursing and rehab center, um, we often use the interact form, to help relay information. What's popping into my mind is, gosh, wouldn't it be cool to have the ABCDEF bundle information, what's been integrated into their care plan in relation to that, that maybe can be continued as they receive care in a different setting.
Absolutely. Or that yes, the patient was positive for delirium in the ICU for 2 days. Like some of those details that are important. I like that
Yeah,
idea.
absolutely. And some of that information is not passed along, as you probably know.
We do have another hand raised.
Great. Okay.
So Donia, you can
Hi,
go ahead.
can you hear me? Hi, everyone.
Hello.
Yep, we can hear you.
Oh, yeah, thank you for the great presentation. That was really helpful. I feel that your research and background align closely with my work. I'm interested in older adults' decision making after IC discharge. And I had a question. Do you think the current ICU interventions like ABCDF bundle adequately prepare older adults for post-discharge self-management, especially in recognizing symptoms and deciding when to seek care, or you see a big gap there? Thank you.
No, I think that's an interesting question, and I'm glad we have some potential overlapping interests. Um, what I see as a potential limitation to the current bundle is that we do focus on pain and anxiety or sedation, but there are a multitude of symptoms that patients report in their post-ICU stay. Fatigue is really common and debilitating, sleep disturbance. So I think there's opportunities to think about additional symptom assessment that needs to happen earlier so we can better manage it and help patients prepare for some of those changes in symptoms that persist beyond their hospitalization and in the weeks following their hospital discharge. But fatigue and sleep disturbance are coming to front of mind to me that I don't see explicitly in the bundle, but are important to patients.
Yeah, absolutely.
Thank you so
Sleep,
much.
so essential. A suggestion that Sarah Songer, one of our nursing alumni, has in the chat. She mentions that when you're attempting to call an ICU nurse manager, that maybe I'm not sure what your strategies are or what your protocol is with that. Are they made aware that you're going to try to call ahead of time? Because she mentions that she personally doesn't pick up a number if she's not familiar with it. So wondering a little bit about whether that might be happening and that's why you're not getting that response.
No, I appreciate that opportunity to help better connect. And yeah, absolutely. We're trying to make an appointment, saying that we're just looking for 10 minutes of your time at a time that works for you. So we're
Yeah,
adding a few more nurses to our team as well to help sort of balance those times, but really appreciate that quick connection with the nurse manager. And then we're also collecting their email addresses if they'd like sort of a summary report of the work that we're doing so they can see their contributions to this needs assessment.
as you were describing the bundle, um, you did mention a few times non-pharmacological approaches. So in your research, are you identifying what those approaches are and doing any, specific integration of those approaches into, the care plans for older adults in the ICU?
Yeah, no. So this implementation trial uses hospitals' existing policies and existing documentation. So when it's present, absolutely. So we are able to pull some environmental modifications that nurses might document around interventions. We know that mobility is sort of the prime intervention in thinking about preventing or reducing duration of delirium. Um, but so one of our challenges is that we can really only pull what nurses currently document.
Right. Yeah, yeah, that would be a challenge. A couple of key phrases you shared as you were presenting that was the more letters in the bundle, the better the outcomes. And the whole bundle is best, but more is better than less. So I think that those are key concepts, I think, for all of us to remember. Um,
I do have a
Diane
quick.
Bartram. Oh, I'm sorry. Is that
No, I was just going to ask you a quick question, Dr.
go
Krupp, to
ahead?
kind of go back to your
Yeah.
these kind of interviews with the nurse managers. I know you mentioned some like preliminary evidence that they mentioned they want more opportunities for continuing education and kind of growth. Have you gotten a sense as to kind of what they're looking for? Are they open to, are there like specific topics, or do they really want in-person education as opposed to the more like online? Do they want mentorship? Kind of what are they looking for?
At this point, we're really trying to be thoughtful about how many questions we ask them. So we're just sort of focused like education needs in general. And then if they describe more, we'll take those notes down. But what we're finding is it relates to sort of specific patient conditions or disease states that, we see this condition a couple times a year, but would like more information about this type of condition or patient management is sort of what's coming to mind initially. One of the strategies nurse managers currently use right now is sort of calling the university health system. So they're making some informal connections, but if there's ways that we could help support that to allow that sort of bi-directional sharing, we'd be interested in thinking more.
So Diane Bartram says she's a previous ICU nurse whose family and friends have experienced delirium and PTSD during and after ICU care, and even after hospital discharge. She really appreciates this very informative and valuable research. So she wants to thank you very much.
You're welcome.
Yeah. So Ahmed, who had raised his hand earlier, is mentioning that he's had some issues with his laptop today. So he was had to restart. Ahmed, are you able to unmute now or put your question into the chat? You're welcome to try that if that works for you.
If not, I'm happy to connect via email after this talk is ended.
Thank you for that offer. That's lovely. Well, we're almost out of our time today. I want to thank you so much for sharing this incredibly important work and all of this wealth of information. I think, you've got many of us thinking about possible ways we could collaborate with you as well, because there seems to be a lot of interest as well as connected work that's happening. So that's exciting. And if anyone has any additional information or questions they'd like to ask Dr. Krupp, we can help to facilitate that. But as a reminder, so thank you again, Dr. Krupp, for being here today and for this wonderful presentation, this great seminar. Thank you to everyone for joining us today. And as a reminder, I just wanted to remind you that when the seminar ends, there will be a link to the evaluation tool pop up. And please fill that out when it's convenient for you. If you can't do it right away, it will be emailed to you within 24 hours. And it does need to be completed within 1 week, especially if you are looking for RN contact hours. So lots of thank yous in the chat, Dr. Krupp, and at CGNE on behalf of our leadership team and our affiliates. Thank you so much for joining us today and for sharing your valuable work with us.
Thank you for your time.